Presenter is Dr. Robert or Rob Quick. Dr. Quick is a medical epidemiologist in the Enteric Diseases Department of the Epidemiology Branch of Centers for Disease Control. He received his medical training at the University of California, San Francisco, his Master of Public Health from the University of California, Berkeley, residencies in family practices and preventive medicine. He's worked in Alaska, Latin America, Africa, and more specifically with colleagues in the CDC and Pan American Health Organization has developed the Safe Water System. Welcome, Rob.
Thank you, and good morning, everybody. Let me see if I know how to advance this. Oh, there we go. Oh, okay. Oh, yeah. Oh. I think the presentation is, sure, it was a really good one. Actually, I'm going to echo some of your comments, too, so, yeah. But just to explain a little bit, there are all these big words describing the branch I work for at CDC. It's really about diarrheal diseases, cholera, also enteric diseases like typhoid. So enteric diseases sounds a little more neutral. It's not quite as much of a conversation stopper as diarrhea. So, but we are a health agency, and my interpretation of this topic, what's the harm, is to talk a little bit about health issues related to water and diarrhea, but also to talk a little bit about prevention, because we are a prevention agency. We got into this business during the cholera epidemic in Latin America in 1991 that swept across all of Latin America. Our job is to work on these epidemics, try to understand why they're happening, and recommend approaches to prevent the outbreaks. We spent several years documenting over and over again that water was really the major issue in Latin America. It was ironic because the water and sanitation decade of the 80s had just finished, and Latin America really had made as much or more progress than any other part of the world. And yet they faced the first cholera epidemic in nearly 100 years that they had had. We found a lot of interesting facts about what was going on. We found that household connections were not safe. These are improved water supplies. These are what WHO calls improved water supplies. But because they were treated irregularly or inadequately maintained, or when there were clandestine connections where people tap holes in the lines, and when you have power shortages, you create negative pressure in the line, and you get contamination entering the water systems, which then become a very efficient vehicle for delivering Vibrio cholera to households. Oops, can I go forward? I didn't realize I hit that. Let's see, oh yeah. We also found that community water supplies weren't necessarily safe. Again, improved water supplies. Groundwater was contaminated in some cases, and then there was this problem of recontamination of clean water through household storage and transport. So this is just a graph from one of our many studies in Peru. It just showed that water quality was pretty decent at the home, pretty decent out of the tap, but the stored water tended to be a lot more contaminated. Same water sitting in a wide-mouth container. So the lesson for us was that cholera was a message. It was an indicator of severe water and sanitation problems in this continent. And cholera is really only the tip of the iceberg. It makes the news, but in 2005, for example, not even 3,000 people died of cholera worldwide, whereas about 1.8 million children under the age of 5 died. About 400,000 children died of typhoid fever, and that amounts to about 6,000 cases a day of children dying. Diarrhea, depending on how you cut it, Diarrhea is the second leading cause of death in children under 5. This is from data from the Lancet. The acute respiratory infections rank first, but nearly 1 in 5 deaths of children under 5 are due to diarrheal diseases. And where do they occur? Well, primarily in South Asia and sub-Saharan Africa. It's a little more graphically shown on a map here, where you can see every red dot represents 5,000 deaths of children under 5. So you really see it concentrated in sub-Saharan Africa and South Asia. 11 countries in the world account for 75% of all childhood deaths from diarrhea. These, I'm not going to read through them, but these 11 countries. And you still find the problem is very severe in many countries in sub-Saharan Africa. In these countries, 20 out of every, or well, let's just put it this way, out of every 1,000 live births, 20 or more children under 5 die of diarrhea in the countries listed here, and there's a lot of countries listed. So why do children die of diarrhea? I mean, we all occasionally get diarrhea, and we do just fine. Well, babies have an immature immune system, and they don't have much physiologic reserve. They're small. They don't have much reserve in terms of water in the body if they're losing a lot. In developing countries, they face multiple insults, malnutrition, frequent infections, particularly in fecally contaminated environments, and they have poor access to health care. A lot of these diseases needn't be fatal. There are other health consequences for the children who survive. There's stunted growth due to malnutrition, lost productivity to the parents who have to care for these children. Decreased cognitive function is thought to be an outgrowth of diarrheal diseases. And then there's this issue of HIV-infected people. There are roughly 30 to 40 million people infected with HIV in the world, most in these parts that are heavily affected by diarrheal diseases. And every time you get an infection, a diarrheal disease, and other infections in someone with HIV, you get increased viral loads. Just means the virus multiplies in the body. This means you start losing your immune cells more rapidly. And the other thing that happens, you're getting sicker, and if you're taking antiretroviral medicines, you're not absorbing them very well. And so it just accelerates the process towards AIDS. So now, that's kind of the bad news of all these things. I do want to talk a little bit about prevention. And, at the time of the water and sanitation decade, there was the dominant paradigm basically said that, based on 2 very influential literature reviews, that sanitation and hygiene had the greatest impact on diarrhea, that water supply had a substantially lower impact, and that the lowest impact was through water quality. So this really guided a lot of water projects in this period. Now just hold on to that thought, because I'm going to return to it a little later. But the problem of diarrhea led to large global efforts. As I mentioned, the water and sanitation decade. The idea was to provide water and sanitation for all. At the end of the decade, we all know the numbers. Over 1 billion people lacked access to safe water, and that's really what I'm focusing on. But that number of 2.5 billion without sanitation also was documented in 1990. In the year 2000, we essentially treaded water. The same figures were used to describe the people without access to water and sanitation. In 2000, the MDG for water was established, which I think recognized the challenge of reaching everyone, and because the goal was now to reduce by half the proportion of people lacking access to safe water and sanitation. Not water and sanitation for all, half. Just recognizing the realities of the situation. And one of the realities is, in terms of water, you need to create access for safe water to nearly 300,000 people each and every day between now and 2015 to reach the goal. A recent report by WHO and UNICEF recognizes that we will not reach the MDG in sub-Saharan Africa. There are a lot of reasons for this. One of the problems is a lot of focus is on infrastructure, and infrastructure has to happen. We need it, but it's very expensive. China recently announced that they're going to provide safe water for all in their country, and they budgeted $125 billion over 10 years. So it's time-consuming as well. It requires political stability and good governance, which, as everyone knows who works in the developing world, it's in short supply. Many urban megacities have compromised distribution systems. They're crumbling, they're cross connections with sewage systems. In these cities with tens of millions of people, it's very difficult to start, to figure out how to improve this. The population at greatest need earns less than $2 a day. And there aren't very good systems to collect money from those populations to support the delivery of infrastructure to their homes. So these are big challenges. Now, our approach, based on our experience in Latin America, based on all the learning we've done about this, is to say, okay, we're a health agency, we're not engineers, we don't do infrastructure, but we can do things for health. And so I just want to take a couple slides just showing what we've done at CDC, it's an intervention we just call the Safe Water System, to give it a name. It involves water disinfection with dilute sodium hypochlorite solution, produced locally, available locally, commercially distributed locally, safe water storage, and behavior change methods, including things like social marketing, community mobilization, and other approaches. So this is our approach, and what we did when we first started this business is we did the research, and we documented that you reduce diarrhea by about half on average. You know, the range is 25 to 85%. We have all these studies are documented in the medical literature for anybody who's interested. We now have programs in 26 countries that are shown on the map. And we have distributed, in the course of this project, over 37 million bottles of solution that each one treats about 1,000 liters of water. So that's about 37 billion liters of water treated. In 2007 alone, about 12 million bottles were sold in 19 countries with social marketing projects, and that amounts to about 6 million beneficiaries per month, which it sounds good, but it's a drop in the bucket. You know, that we have a long way to go. And since the time we've been working on this, a number of other options have become available, which I'm sure most of you are familiar with. Anything from biosand filters, which you're quite involved with here, solar disinfection, ceramic filtration, Pure, which is a flocculant disinfectant. All of these interventions have been studied, data have been collected, and this brings us back to this dominant paradigm in water and sanitation that I mentioned earlier. Whoops, could you, this is going back here to the white bars represent the studies by Esri that I mentioned before. The blue bar represents a study that was commissioned by the World Bank that was recently conducted, a literature review of all relevant literature in the water and sanitation area. And we find that sanitation and hygiene have the same effect. It's a beneficial effect. There's no question that there are gains from those. Water supply, somewhat less, still important, and water supply is important for other reasons than just health. But water quality, look at this. This was the dominant paradigm before. Now we found that the impact is about double what was found in that earlier review. Why was this? Well, that review compared community-level interventions. It's unclear whether the differences resulted from infrastructure or programs, and these really weren't randomized controlled trials. A lot of them were rather weak. It also didn't take into account what happens between the water source and the point of use. We know now from many studies that stored water is usually more contaminated than source water. Stored water contamination tends to increase over time, particularly if there's organic material in the water that allows growth of microorganisms. And consumption of stored water has been shown in a number of studies to be associated with disease. So this intervention is taking place at the high-risk zone between water collection and use. And again, as a health agency, this is what we really focus on. How do you prevent disease? So now I just want to take a couple minutes on some lessons learned. And these really echo a lot of what Ron said. We now know that consistent use is critical to have health impact. This is the behavior change thing. People have to change and maintain the change. We also know that access to technology is limited, severely limited at the base of the pyramid. Those 11 countries with 75% of the deaths, most people in those countries live at the very base of the pyramid, and they may not be able to afford anything. Food may be their first priority. We also know that one size does not fit all. You know, the technology should be appropriate for local conditions, should be demand-driven, as Ron mentioned. And each technology has strengths and weaknesses. I just want to throw this up there. I'm not going to go over it in detail, but this is from PATH. I was recently in a meeting. Glenn Austin sent this to me. It's basically from an article by Stu Hart and Ann Reck that just basically evaluated how each of several point-of-use technologies does with different categories of health or water issues such as turbidity, heavy metals, microorganisms, pesticides. As you can see, each one has strengths and weaknesses and kind of need to be considered when in implementing it in certain areas. Now, there are challenges that I've alluded to earlier. Achieving sustained behavior change is number one. This is the software. I don't care what technology people are using. It's like a hard drive that doesn't have anything running it. The software is going to drive anything we do. I don't care what project it is. Scaling up has been a daunting challenge. How do you reach perhaps 3 billion people in need? Because that 1 billion figure of WHO is a gross underestimate. The sustainability of different technologies, this is really talking about what Ron mentioned. Production, maintenance, repair, replacement of parts. That's probably the biggest reason for failure of a lot of projects, because those haven't been considered. And then there's the economic sustainability of these interventions. There are many opportunities, though. Again, it's really echoing Ron. Consumer choice is important, so I think the more technologies that are available, the better. There are many promising new technologies coming on the market that need to be studied. LifeStraw is one. LifeStraw I don't believe is ready for prime time yet, but it's being studied now as an example. Implementation in a variety of venues is also needs to be considered, because the household's one level, but just to give you some pictures of other possibilities, we have projects in clinics in Kenya, where clinics that didn't have water. Imagine health workers not being able to wash their hands. Imagine having patients who can't take their antiretroviral medicines with safe water, so you negate the effect. We've put hand washing and drinking water stations in a number of clinics now. It's something like between 50 and 100 in Kenya. And use these stations to teach mothers or other patients about safe water and hygiene. In one evaluation we did, we got 60% uptake in the mothers of water treatment, just a locally available water treatment technology by mothers coming to a maternal and child health clinic. School programs. This is an easy win. And again, we've put drinking water and hand washing stations in a number of schools. We have curriculum we've developed for teachers to teach children so they can go home and teach their parents. We did an evaluation a couple years ago and found absenteeism decreased by 35% in schools where we implemented this. Disaster response. Particularly if you have point-of-use strategies that are portable, you can respond. We've responded with the Safe Water System to a variety of different disasters in different parts of the world. This doesn't want to move. Oh, there we go. Again, as Ron said, working with women's groups. We have income-generating activities in a project with an NGO in Kenya called the Safe Water and AIDS Project. This is a Rotary-funded project, by the way. Women receive business and health training. They teach their neighbors. They have a basket of health goods, including water treatment products, soap, and other things. They buy it wholesale, sell it retail, keep the difference. And we've we're providing access to microcredit to help them get started. And right now we have 1,300 women borrowing, and we've got 100% repayment. The project should be self-sustaining within a couple of years. Finally, you can implement this through programs like the President's Emergency Plan for AIDS Relief. We've shown that by just providing the safe water system in households of people with HIV, we reduce the risk of diarrhea by 25%. And now water treatment solution and safe storage containers are provided to people with HIV in Uganda, Kenya, and Nigeria. And there are other programs like that. These are easy things to implement. And so it just, there are many venues to think about as you implement. So finally, just to finish, we really need a new paradigm. We can't, we have to assure infrastructure. Water supply is important. But in the short to medium term, we need to think about protecting and improving health through the use of simple, inexpensive technologies. Technologies can be combined for synergies. Partnerships, as Ron mentioned, are critical. Interventions should be designed to meet local needs and desires. And we need to figure out ways to assure access to the poor, those people who can afford food and maybe nothing else. Resource limitations demand innovation in terms of implementation, and evaluation is my last message. Evaluation is critical to maintain the learning. We can't, as Ron said so well, we can't just assume that once you finish a project it's going to work and go and work on a continuing basis. I think I'll stop there. Thank you very much.